All right, my name is Dr. Afenya, and basically work with Les Kidney Care in Lexington, Kentucky. And today we're going to be talking about one of my favorite topics, hyponatremia. To set the ball rolling, we're going to look at the background of hyponatremia. What exactly is hyponatremia? Hyponatremia just means sodium concentration that is within the either vivo or ex vivo that is less than 135, and the serum concentration refer to ions that are measured in either coagulated blood ex vivo. Now, what are the clinical significance of hyponatremia? One, it increases mortality. Two, it impair attention, mentation, and slowing even when mild. And in some cases, it's a predictor of hepatorenal syndrome, hepatic encephalopathy, and death in patients with liver disease. So the other things you look for is that hyponatremia is a risk factor for gait instability, falls. Patients with osteoporosis, can develop fractures and things like that. So when somebody has hyponatremia, it's really important that you look at how to prevent it so that people with osteoporosis and gait instability falls will not have fractures. Now, the other thing to look at is that there's also an associated myocardial fibrosis and evidence of early senescence in rats. So we want to look at an equation called Alderman equation. Alderman's equation just gives us the plasma concentration of sodium, and if you add the plasma concentration of sodium and potassium and divide it by total body water, that gives you Alderman's equation. And this equation actually represents the sum total exchangeable body sodium and potassium ions. Now, what are the predictions through Alderman's equation? The Alderman's equation will help you in acute hyponatremia. It also helps you determine the free water shift within the brain cell causing brain swelling. So these are very important numbers you want to look at. And also, it also helps you with neurologic complication and even death, due to confinement of the brain within the skull. Now, the prediction through Alderman's equation also has two major determinants of body tonicity, and this is ADH and TESS. And these are some of the things that you can see on an MRI. If you do an MRI of the brain, you see pituitary bright spots, and that is actually, that bright spots is consistent with lack of ADH. And the equation also help indicate the disorders of water balance that can cause changes in the plasma sodium concentration. What are the clinical features of hyponatremia? The clinical features of hyponatremia depend on the risk and severity or the degree of the hyponatremia, or also on the rate of change. So for instance, if you have a sodium level of 135 and it drops suddenly to 120, that's a sharp change. And so that's how we look at it. And to classify it, we have the mild form, usually asymptomatic to minimally symptomatic. Then the moderate. In a moderate, you can have headaches. Some patients can present with lethargy, nausea and vomiting is another presentation. They can have disorientation, muscle cramps, and reduced reflexes. Now, in the severe form, which typically your sodium level is less than 115, they can have encephalopathy, they can have seizures, coma, respiratory arrest, brainstem herniation, and even death can be one of them. Now, how do we classify it though? before you classify it, we need to look at something that we refer to as pseudo. Pseudo is false, right? So pseudo hyponatremia is falsely low measures serum sodium concentration. This can be manifested in two ways. One, either you have severe hyperlipidemia or you have hyperproteinemia. So patients with multiple myeloma and patients with disorders of lipid may show hyponatremia, but it's actually a false hyponatremia. Then under this, we also have hyponatremia due to extracellular free water shifts. So an example of that is hypertonic mannitol or hyperglycemia, or in some cases severe levels of sucrose or maltose. So the first one we talked about the hyperlipidemia and hyperparaproteinemias. Then the hyperglycemia and hypertonic mannitol are also examples of pseudo hyponatremia. Then what about true hyponatremia? That is where after somebody comes in, you now determine that it is not false hyponatremia and it's actually a true hyponatremia. How do you then classify it? This is true because the content of the sodium relative to the volume is what determines if this is hyponatremia or not. And so in this case, you're talking about increased free water retention, you're talking about excessive sodium loss, or both, leading to a state of hypoosmolar state. The first classification to look at is hypovolemic hyponatremia. Hypovolemic hyponatremia, in this case, you have appropriate increase in ADA secretion plus high water intake, and then you also have an associated increased renal salt absorption. So all this combination, culminate in a state where you have low volume and then you have low sodium level. So the renal salt wasting to volume depletion to appropriate increase in ADA secretion plus high water intake. It's typical example of hypovolemic hyponatremia. Then we come to euvolemic. This is where it becomes a little confusing, but if you understand the concept very well, the person comes in, you check its volume status, it's euvolemic, but it's hyponatremic. It's typically seen in SIADH, which is a very typical clinical scenario. So in that state, euvolemic hyponatremia, you can have two types. You can either have ADH dependent or ADH independent. ADH dependent is what we see ADA secretion is inappropriate, and that's what we see in SID. It's very clear, typical question we ask on boards. Then hypovolemic hyponatremia, and in this case too, you can have two types. You can have either ADH dependent or ADH independent. With the ADH dependent, we have dysregulated continuous ADA secretion due to conditions associated with reduced effective circulatory volume. So this is important because typical example will be somebody who comes with congestive heart failure. They have hypovolemia, the ADH is secreted because there is decreased effective circulatory volume. Then you can have a situation where you have ADH independent. Typical example is SIADH people or people with end-stage renal disease, who have kidney failure and they have poor diluting capacity. Now, one of the things you always have to look at is when a patient comes in with a hyponatremia, you always have to sit down, go through their medication list, and I can promise you, you come up with one of the medication as the cause of the hyponatremia. And sometimes we panic, and the simplest thing to do is to just discontinue the medication. Now, so we're going to look at the drugs affecting both sodium and water homeostasis. And one example is diuretics. And then drugs also affecting just water homeostasis. And then drugs that are causing what we refer to as reset osmostat. And we'll come to reset osmostat and we'll try and explain exactly what reset osmostat means. Now, typical drugs that are associated with angiotensin converting enzyme inhibitors, then we have intravenous immunoglobulins mixed with in maltose and also in sucrose, and then another example is amphetamines like ecstasies. Now, drugs associated with hyponatremia a lot. So this is where colchicine comes in, dopaminergic agents, unfractionated heparin, clonidine, hydroxyurea, even name it, tacrolimus, proton pump inhibitors, and glyphosate, all example of drugs. So it's important that when you see a patient and they call you, patient has hyponatremia, you want to sit down, go through their whole medication, step by step, looking for a culprit in the just going through that list and picking up that drug is really important, because the only thing you have to do is to stop that medication, because there's a tendency to send for a lot of labs. You're taking TSH, you're sending serum osmolality and doing that. Before you even send all those labs, you want to make sure that there is not a drug on a patient list that is actually driving the hyponatremia. Then, how do we manage it? This is really important, because before you even go into management, your biggest thing is to make a good diagnosis. Because if you don't do a good diagnosis of the etiology, then you will be managing it in a different way. One of the biggest thing we do, if it is associated with hypovolemic hyponatremia, fluid restriction is a big thing that we use. So in euvolemic as well as hypovolemic patient, fluid restriction is the number one thing. Now, sometimes in a hospital, you have to be very specific. A patient will come in and will order fluid restriction. The person doesn't realize that. They say, oh, don't take fluid, and he's just thinking it's only the water that you drink. No, you also thinking about anything that has water content, the clear fluid, anything that fluid in it. You have to factor all that in as part of the fluid restriction. Not just water, but tea, coffee, anything that the patient is drinking, you have to factor all those in. Then for patients that are euvolemic, you can add, the basic thing you're doing is that you have low sodium, right? You have low chloride. So you give them sodium or you give them chloride. But in what form do you normally give this? You can give it in a form of normal saline, which is fluid that we give all the time. You give it in the normal saline form. Now, if a patient comes in, typically not long ago, I had a patient, 117, having a seizure, and in that case, you have to use a 3% hypertonic saline. Now, it's important that they have to have symptoms. If a patient comes in with no symptoms, no decrease in mentation, you just have to go with fluid restriction, because you don't want to overcorrect. And like I said, mostly if they have the sodium level less than 115, then you have them having seizures and things. But like recently, just about 2 weeks ago, I saw this patient, 117, and he was having seizure. In that case, you have to give hypertonic saline. Now, what other treatments do we have? Increase renal water excretion. Like you can have a situation where there's a lot of water load, or you correct the underlying condition. Somebody has CHF, you try and augment, and then patient is on dialysis, is volume overloaded, so you use dialysis to correct that. And then also management of overly rapid correction of hyponatremia, and that's one key because it's one of the things that lead a lot of people to more practice and things, because you want to make sure you're doing that correction slowly. Slowly is the key. Yeah, so we're gonna end here, and we're gonna come back again. Thank you very much for being a part of this discussion, and hope to see you again.